My name is Greg Pereira. I am a Rising Chief resident, and today we're going to be talking about skeletal traction. And I'm joined here by John. John, you want to introduce yourself?
My name is John Kodosky. I'm an ortho trauma PA at San Antonio Hospital, or at University Hospital in San Antonio, Texas.
Beautiful. All right, so just to begin, John and I both have this disclosure. It's our only disclosure. We're both consultants for Arbutus Medical. They're a company that does a lot of innovative work in the skeletal traction space. However, this whole webinar is going to be predominantly educational. And I'd like to also mention, you guys can stop me anytime. Use the chat or just buzz in if you have any questions, because I want this to be conversational, and we'll also have a discussion at the end. So when thinking about skeletal traction, you have to think, what are your goals? I think one of the first goals that I think of, is frequently to decrease blood loss. If you remember, we do this oftentimes for, long bone injuries like, femoral shaft fractures. And if you remember, the medulla has hypervascularity, it has hematopoietic stem cells, and it just bleeds a lot. So actually, by pulling the bone back out to length, it creates a tamponading effect and can decrease blood loss. Second, you can see in this image, with a lot of these injuries, you get these large bony spikes that are sitting in the musculature, and that creates obvious pain and it can create muscle spasm. So by getting them in a more anatomic location, that will decrease both pain and spasm. And third, for a lot of these injuries where you end up getting an entrapped fragment or incarcerated fragment in the joint, which we'll talk about in the next slide, it actually can prevent chondral injury by distracting across the joint and preventing that entrapped fragment from grinding up all the cartilage. So kind of as we mentioned, some common indications here, we talked about short and femoral shaft fractures, but unstable acetabular fracture dislocations in the setting of large posterior wall fragments are another common thing that I see. These are, again, the fracture dislocations that you reduce and that quickly kind of redislocate very quickly. When you get a CT scan, you may see something like what you'll see is something like the image on the top center, where you'll see a fragment that just is not attached to the remainder of the femur, and again could be grinding in that chondral surface. And that is truly what we talk about when we say incarcerated fragments of the acetabulum. The last one I'll say is the vertical shear pelvis fracture. It's a very rare high energy injury, and it's a scary injury to see. But I just kind of want to emphasize this for everybody on the line, because on your boards, just like in pelvic ring injuries where you have anterior diastasis, and the answer is to immediately use a pelvic binder to decrease pelvic volume. Vertical shear pelvis fractures, the book answer, in fact, is to use skeletal traction to help reduce that hemipelvis back to a more anatomic location.
And the other pearl that I'll contribute is make sure that you're getting your CT scan after the hip has been reduced to ensure that you don't have any incarcerated fragments. It's easy to not see them if the hip is still dislocated on the CT scan, or you may actually create a fragment as you're trying to reduce the fracture. So make sure that you do that, and that way you don't miss that.
Absolutely. And telling the ED not to just don't get the CT before you reduce it will help. So the first thing that we are going to do is talk about femoral traction. This is something that in my center, we do probably the most of, and it's something that I've done a lot of in my practice. So to kind of scope it out, I kind of created a 7-step guide to perform the procedures, and we'll go through step by step. If you have any questions, just stop me as I go. So the first step, and this is for all traction in general, is to set up your materials as best as you can. It's going to instill confidence in your patient, not going in and out of the room a bunch of different times, and it's going to frankly save you a lot of time. To do traction, though, you're going to need a traction bed. You're going to need something to drive the pin. You're going to need a tensioner, which is this metal item down here called a Kirschner bow. And then you're going to need a variety of items, including lidocaine zeroform and the like, to actually perform the procedure and to dress the pin subsequently. So if you don't do this procedure a lot, it's nice to have a cheat sheet. This is actually from a picture from a pack that includes all the items to perform skeletal traction. But just knowing what you need beforehand and bringing it all to the room, like I said, is a very critical step that will save you time and energy. The next thing that I have is, especially for femoral traction, to bump and derotate the leg. I mean, we mentioned before that a lot of times people come in with hip dislocation or femoral shaft fracture, and they're shortened and they're rotated. So by derotating the leg, you're going to make sure you can see the medial and lateral side of the thigh, which is going to be mission critical when driving the pin. And then to actually bump the leg, especially in larger patients, will save you a little bit of effort in dealing with the contralateral uninjured large thigh. So I always bump and derotate when I'm going to do femoral traction. The next thing you're going to do is draw out your landmarks. So one of the first landmark I personally draw is the superior pole of the patella, although you can just draw the whole patella if you'd like. Drawing the tubercle is just helpful for me, so I always draw it. It's not that necessary for this procedure, but then the joint line is very important for the procedure because you're going to want to drive the pin in a way that's parallel to the joint line. To do this, you're going to go 2 to 3 centimeters proximal to the superior pole of the patella. That'll prevent you, when you're putting your pin, from creating a traumatic arthrotomy. Because if you remember, that capsule extends kind of proximally on the femur. And for me, that's 2 or 3 finger breaths, for a quick measurement. The next thing is to use lidocaine. So obviously patients they have had a painful injury. They're very stressed when you explain the procedure to them often. So to really try to make this as painless as possible, I typically use around 20 cc's of lidocaine. If they give you a 5 or 10 cc bottle, you're going to say I need more, because I use typically 10 on each side. I put a good amount in the soft tissue, going down to the bone, but I think a really important thing is to put a lot of lidocaine at the periosteum. Periosteum is really hyperinnervated tissue. And if you think about it, the pin, when it touches the actual bone and starts spinning, it's going to create heat, and that's going to create a lot of pain. So by numbing the periosteum, you're going to really lead to a more comfortable patient throughout your procedure.
My clinical pearl there is, don't forget that lidocaine takes 1 to 2 minutes to kick in. Don't be in a rush. Do that early on while you're getting your hands and everything else organized. That way it has time to kick in.
Yep, that's an excellent point. So then steps 5 and 6. So we'll start with 5. Once the lidocaine has taken effect, you can take your pin and you take it down to bone, and then you're going to do what I call the A to P, anterior to posterior march, and you're going to try in your mind's eye to figure out where the center of the bone is. So that means marching the pin anteriorly until you fall off the anterior edge, marching it posteriorly until you fall off the posterior edge, and then trying to be right around the middle or anterior third. That'll allow you to drive the pin and to be bicortical, which is really important when doing it. So then you drive your pin, as we said, and once you've driven the pin and you've taken off your pin driver, etc., you're going to dress it. So what I personally do, and this is different in different people's practice, is put Xeroform around the pin to prevent, or minimize risk of infection, and then I take Curlex and I wrap it around that Kirschner bow, that tensioner, so that it doesn't rest directly on the tibia. And then the last thing is the K-bow and the traction bed, which, like I said, you put the K-bow to tension the actual pin, especially if you're using a 2 millimeter pin that's quite flexible and pliable. And then you're going to attach it to rope and to your weights, which attach to a pulley system on this bed to allow you to pull axial traction through the long axis of the bone. So the next form of traction we're going to discuss is tibial traction. I again created kind of a 7-step guide, and a lot of them you'll see are pretty similar to the femoral traction. But the first step is, again, to set up the room with your itemized materials. Again, instills confidence, saves you time. Definitely worth doing it on the front end. Derotating the leg is really helpful. I mean, here in general, you can definitely bump it. I frequently do. I think it's less important because the thigh tends to be a lot thicker and fatter than the kind of calf region where you're going to be, or the shin where you're going to be driving the pin. But derotating the leg is obviously very important because in this case, you're going to be, you have to see both the medial and lateral edge to actually drive it. So the next step is going to be drawing your landmarks. In this case, again, you draw the joint line because you want to be parallel to the joint line here. So you'll see it right here, up here at the top. But essentially, you're going to be you're going to draw the 2 to 3 centimeters relative to the tubercle to actually drive the pin and to be away from the common perineal nerve. So that's the one thing I want to remind everybody when driving the pin. When you're driving it for femoral traction, you're driving it from medial to lateral to avoid the dangerous structure of the femoral vessels. In this case, you're going to drive it lateral to medial because you have more control and you want to stay away from the common perineum. Next, you're going to use lidocaine. You're going to do the exact same thing. You're going to numb up the soft tissue. There's not as much soft tissue in the tibia. And essentially, all that means is, you're going to go right down very quickly to periosteum, and you can use a lot of lidocaine to kind of numb it up and wait your 2 minutes, as John said. Then you're going to drive the pin. You can see again here from lateral to medial. You drive the pin, and then essentially you just, in this case, you would, you can do this differently with DeWalt drills, with striker drills, etc. But once you've driven the pin, you're going to make sure you go to the next step, which is dress the pin. You do that with Xeroform. I use the exact same setup. I put Xeroform around the pin. I use Curlex around the Kirschner bow, and make sure that the Kirschner bow isn't sitting directly on the tibia, which can lead to some pressure sores depending on how long it's there. And then finally, you take the K-bow, you put some rope on it to attach it to the weights, which are hanging off the edge of this traction bed. So all in
I'll
all,
throw
yep.
Sorry, I'll throw two things in there real quick. If you could go back one slide, please.
Mm.
You've been appropriately mentioning how we want to stay parallel to the joint line. The other thing we want to do is make sure that we're parallel to the bed as well. We don't want to start high and be shooting down, or start low and shoot up. So we got to make sure that we're parallel with both the joint line and with the bed top to bottom. And that's why it can sometimes be helpful to have somebody at the foot of the bed holding the leg almost as counter pressure, helping to derotate that leg and to make sure that you don't have your hand too high, too low as you're shooting. And the other thing that we can agree to disagree on is I do not wrap the bows in Curlex. I like to be able to see if the bow is touching the skin or not, even as I'm just walking by the room. Patients can still sometimes get skin breakdown if the bow is really pushing down. That Curlex does not offer enough padding, and they'll still get pressure sores. So a lot of our residents at University Hospital do that. I don't criticize them for it. I certainly would not do that in this arena. I have my preferences, you have yours, and we'll still get along. But my reasoning is that way you can just see it as you're walking by the room. It's a little easier and cleaner.
Totally. That totally makes sense. And one last thing I'm going to say, because I think I messed it up in one of the previous slides. When you draw your tubercle, you're going to be 2 to 2.5 centimeters posterior, and then 2 to 2.5 centimeters distal. So that is the appropriate location. I think in one of the earlier slides it said the wrong thing, and I just wanted to make sure I emphasize that to you guys, because again, I use like 2 of my fingers, go 2 centimeters posterior, 2 centimeters distal, and then I drive the pin. And as John said, people have different preferences in actually dressing the pin. But I think, again, as long as you're following the key principles of this, you're gonna keep out of trouble. So calcaneal traction, I was going to turn that over to John, because frankly, it's something I personally have not done a lot of in my practice, and he may have some better pearls for you if you want to take that, John.
Sure. Calcaneal traction is one of those things that I like to mention, but I don't necessarily teach. I've been doing skeletal traction now for the better part of 15 to 20 years. I've lost track. In those numerous decades, I've been a part of calcaneal traction less than 10 times. So there are very, very few reasons to do it, but I do like to teach it because it's something that you need to keep in your arsenal. The instances where we had to do that where the patient had a significant hip dislocation that was unstable, and they had road rash down the entire side of their leg, and we were simply unable to put pins through road rash. So we ended up doing calcaneal traction. The pearls are exactly the same as whenever you're doing a delta frame for a pilon fracture, a talus fracture, or something like that. All you're doing is using a smaller pin, and you're doing it outside of the operating room. So you follow your same landmarks. You're still going medial to lateral so you can avoid your important structures. You're still putting the tension bow on the same way, and you're still putting the bed set up the exact same and dressing your pin the same way. So just have this in your arsenal. And if you ever find yourself in a scenario where you need to do calcaneal traction, Google it, YouTube it. There's a video out there on it. I promise you that.
And one thing for the ortho folks, because I personally don't do this, right? But that being said, I've put on 1 million delta frames for fracture dislocations of the ankle, for pilon fractures, etc. And the actual placement of the calcaneal pin is very similar, is exactly the same, in fact, to what you do to a delta frame, calcaneal pin. It's just bigger. So use your same principles if you do that in the OR, and I think that'll also help you. So, thinking from a high level, I think now we've given you 3 different options. So you say, which do I use? And I think one of the first things is what is done at your institution. There's a lot of institutional variability, and some people have very strong opinions. As you may know, in orthopedics, people tend to latch onto what they were taught and go with it. So knowing what's done at your institution is valuable, and I think is a good place to start. Another thing, this is a little bit higher level, is where are your incisions going to be? I mean, one thing that's very clear is you don't want to be putting pins near a potential incision, and that's sometimes hard to do because you maybe not be the one fixing the fracture, but having a femoral shaft fracture that may or may not extend distally into the to the interarticular surface, that may be something that you want to put a tibial pin in. because you may be waiting for a CT, there may be a bunch of different variables. But if you're worried about an intra-articular extension of a distal or of a femoral shaft fracture that just goes all the way down, you don't want to put the pin in the distal femur because that's going to be right in your operative field. Another thought, this is something that I've been told now, there's no data or evidence that I've seen on it, but it's something that's interesting is, a lot of these injuries happen via a dashboard. It's a classic dashboard injury where, you get a posterior hip dislocation or fracture dislocation. And in those cases, people oftentimes get multi-ligament knee injuries. And it's very hard to get a knee exam when people come in these like polytraumatized settings. So some people have mentioned that, in the setting of a multi-lig knee injury, you don't want to be putting a pin through the tibia where you could be just pulling on the neurovascular structures posteriorly. That's some of the reasons that I've heard people say use femoral traction pins when you can, because then you're truly just pulling through the bone. But like I said, all things to think about, trying to think at a high level, what are the other injuries that are occurring and what should you be doing is going to be just helpful for you in making a clinical decision. And then the last thing is there a reason not to apply traction? This is just one thing that I kind of threw on for kind of similar to what John said about making sure you get the CT scan after you reduce the hip. Similarly here, if you get a femoral shaft fracture in a young person in particular, make sure you look at the femoral neck because there's all sorts of questions in on our boards that say what is the rate of an ipsilateral non-displaced femoral neck fracture. And I think it's about 9%, and that gets missed a significant amount of the time, and that can be a very big problem. So just make sure you get the full workup before you actually apply traction. Try to think through it and think, is there a reason not to do something? If you have an ipsilateral non-displaced femoral neck fracture, you may want to talk to your attending or talk to other folks to make sure that you don't want to be pulling really hard on this distal femur and maybe displacing the femoral neck. So all things to think about, but I just like to put all these down there so you can think kind of through why you may choose one over another. I'm not sure if you have anything to add there, John.
The only other thing I'll add on too is something that unfortunately comes in everywhere with all patients is actual leg size. If you have someone who has a very, very large thigh, you may not be able to get the bow onto the pin without causing significant skin breakdown. We have a patient in the hospital right now like that, where the pin was put into the femur, the bow was put on, and as this person was intubated and laying there, they formed pressure ulcers around the pin itself. So we actually had to pull that pin and then put in a tibial traction pin simply because there was less soft tissue envelope to push on that bow. So you have to remember, you don't want that bow touching the patient anywhere. You only want the bow touching the pin.
That's a great point. And that's something I feel like as we get larger as Americans that we have to think about very significantly. So great point. So I'm just going to throw some of my pearls. I think it goes without saying, talk to the patient. This is probably one of the worst days of their life. They just had a femoral shaft fracture, a fracture dislocation of their acetabulum, et cetera, et cetera. So this is a scary moment at baseline, and now you're about to do an invasive and scary procedure at bedside. So talking them through it and being a doctor, I think, is just a very good, thing to remember when you're walking in that room, because you may be playing all these steps in your mind, but when you're first doing it, but at the end of the day, this is just good patient care. The next thing I have is use more lidocaine than less. Frequently in the ER, they give you 5 mil. This syringe, you can see this vial is 5 milliliters. Get more lidocaine. You're not, in general, using 20 cc's of lidocaine, you're not going to give them lidocaine toxicity. And to John's point, wait the 2 minutes. Politely request the family to leave the room. I've seen this go right once or twice where somebody didn't, and nobody wants to see you drive a pin across their loved one's leg. It's just something you can say that, like, in general, we like to have the patient's family leave the room. We know you're there to be supportive. However, we're going to be doing a medical procedure, and similarly to how you wouldn't want a patient in the OR, you don't want a patient there while you're doing this. And know your steps. If you can do, there's the kind of talking shop that you can do, obviously, with like a senior resident and things like that in the room. But when I do this with juniors, I try to do as much of that as I can outside of the room, just to give them the high level forest, not the trees. And then naturally, you can talk about the little things without making people think that this is the first one that you've ever done. John, I'm not sure if you have a bunch of others to add, but please feel free.
No, I think those are great points. And I cannot stress enough the talk to the patient part. Communication is everything. Just running up to bedside with a drill and a pin and stabbing it into somebody is not a good way to take care of your patients. The other thing that I will add on there, I have taught literally hundreds of people how to do skeletal traction pins. And the very first thing that I teach is get yourself organized. So that's kind of, a subset to know your steps and inspire confidence. Have all of your stuff there. Have it on a Mayo stand next to you. If you're right-handed, have it where it's on your right hand and have it all laid out. Don't use the patient as your table, your work surface. And I've seen plenty of residents start laying stuff across the patient's chest, and that never works. The patient moves and it goes flying all over the place. So make sure you have yourself organized, have everything open that you're going to need in the order that you're going to do it. My biggest pearl in that I have said over and over and over again until I'm blue in the face, just because you are not in the OR does not change how you have your setup process. I watch residents and faculty and colleagues set patients up, spending 20, 30, 45 or more minutes getting a patient positioned properly in the OR, drawing out your landmarks and all those things. And I have seen so many people not take 30 seconds and raise the bed to their own height. I'm 6'4". I'm not using the trauma bed while it's down at its lowest setting. I'm going to boost that up. I'm going to position that leg. I'm going to derotate it. I'm going to make sure it's boosted. I'm going to do all of those things. Make sure you keep yourself organized. Act like you're in the OR, even though you are not. And the procedure will go much, much more smoothly. This is a very simple procedure. The hard part is getting yourself organized and doing it.
All great points. Ergonomics are very valuable too. I'm 6'2" and I have the same back pain after I forget to do that. So I totally agree. So pitfalls here, bumping the leg for femoral traction. I think, in these settings where you have a large patient, it just makes it really, really difficult when you have minimal space between the thighs. I think derotating the leg, as needed is always very helpful. The last thing you want to do is start driving your pin, have everything sterile, and then realize you're going to end up in the bed on the other side. Ask for help. I think that's one of the biggest things, in general. I think if you're like polite to nurses and other people in the ER, NAs, whatever, if you just tell them, what they can do to help you, they're generally very receptive. And if you're, flying solo at a hospital and you need somebody to give you counter pressure while you drive a pin, ask for somebody. You don't need an orthopedic surgeon to do that. And people are very receptive in my experience. Apply the weight slowly. I think it goes without saying, if you just slam some weights on it, it's going to be pulling really quickly across the bone. So just apply them, gently, and you don't have to wait there for 10 minutes to do it, but, do it within reason. And then check the pin diameter and the actual pin for threading before driving it. A lot of times there are threaded pins. There are pins that are 4 millimeters, 3 millimeters, everything under the sun. So just know what you're actually using. Just as John said, just as if you were in the OR. If anybody has questions, would love to answer them.
We got one in the chat. How long does a standard femoral or tibial traction procedure take from start to finish? So that's an excellent question. From the time that you make let me speak from my perspective. From the time that the decision is made for me to say, I'm going to put a traction pin in, until the time that it is done, can take anywhere from 45 minutes to an hour. And that has everything to do with availability of materials. And me physically running around grabbing bed setups, grabbing bows, grabbing needles, grabbing lidocaine, syringes, all of those things. If I had everything right in front of me, the actual procedure, like once I have myself all set up, less than 5 minutes. Goes very smoothly. It's a very quick and easy procedure. The difficult part is the pin size. The difficult part is the setup and getting everything. The next question is what goes into picking pin size. We'll get into that in a second. Go ahead, Greg. How long does it take you?
I have the exact same experience. Actually, I think that's actually both why I think John and I, and talking with him offline, we work with this company, because the difficulty of the procedure isn't the procedure. It's a simple procedure. It's getting everything together. And that's across a lot of institutions. The bed lives in one place, the cabo and the pin lives in the other, et cetera, et cetera, et cetera. So figuring out also where those items are might make your life a little bit easier to see if you can more quickly, even if a femoral, if somebody has a femoral shaft fracture, getting those items together is going to make you be more efficient with your own time when on call. But I echo everything John said about the actual timing, like 5 minutes once you actually have it all set up.
And the next question is, in your experience, how many traction pin placements does it take for trainees to become proficient? In my experience, it takes maybe 1 to 2 on a cadaver. doing the simulated stuff like the sawbones is helpful to get your hands organized. The cadaver really solidifies that. And then about maybe 2, 3 at most on a live person. And after that, they're off and running.
Yeah, I agree. I think that if you can get your hands on a model and do it on a person before you go to the to the ER and do it, you're going to feel a lot more proficient. To be honest, in my experience, I did my first one on a live human being, and I tried to, it took me probably 3 or 4 goes to feel very confident. But like I said, for senior residents, or if you're a junior and you're talking to your senior, try to go through the steps outside of the room just so you can see the forest, not the trees. They can always give you the little tips and tricks, but just knowing the broad strokes is going to help you a lot.
Next question is, what goes into picking pin size? If you want my opinion, the only pin that should exist is a 2 millimeter pin. A 4 millimeter pin is about the thickness of a Sharpie. It is a massive thing, and it is the Calcaneal X-Fix pin. It's that size. That is a huge hole to be putting into the tibia or into the distal femur, and it can cause iatrogenic fractures. So for me, a 2 millimeter pin all the way. There's a lot less incidence of pin site infection, fractures, non-union, or other complications, not non-union, but where the hole doesn't fill in afterward, and can cause a stress riser. So for me, 2 millimeter all the way.
Completely second that. That's all we use at our center as well. I will say that I think the rationale, just so you know why you would use a big pin, is you may not need the Kirschner bow because it is so thick and it won't bend. But I agree with everything John said. Sorry, Nancy said last. We'll answer
Yep.
the rest.
We got one last question here. Can I give any insight on how to avoid pressure necrosis of the skin? Do you raise the frame at the foot of the bed to ensure the bow isn't touching the skin? Yes, that's what I do. We have the old Zimmer setups that are older than me, and that's getting pretty old these days. And you just want to make sure that it's off the tibia and elevated. Let's see, how much tension do you apply to the bow? I tighten it down as much as I can, which I can tell you in testing is about 100 foot-pounds. And that'll hold 30 pounds pretty easily. Considerations on what considerations do you have to take into account if the patient has a total knee? Excellent question. Don't hit the knee. You should be proximal or distal to it.
Then that brings a good point of knowing what the implants look like, because if you have a femoral shaft fracture or something that's like a subtroche, you want to see the knee. So make sure you get a knee x-ray because, mistakes can happen. So that's a great point.
Yeah. The last one I'll do quickly. How does traction fixation compare to a femoral nail with respect to outcomes and recovery? Nothing beats a nail. Nothing beats a nail. No, traction, you have to sit there for 6 to 8 weeks. That's how our grandparents and great-grandparents had their femurs fractures heal, and that's why they died. So, yeah, nails, get up and run. That's 30 minutes, so I guess we're done. How long can these stay in? They can stay in for as long as an X6 can. I like them to stay in for less than 24 hours. So we'll call it with that.
Yeah, I mean, I guess while we still have you guys here, just to jump off what John said, like the history behind it. If you're an ortho, look at damage control orthopedics. Look at how before they had intramedullary fixation, they did these things, and people would be put in traction for weeks and weeks and weeks, and they would get DVTs and they would get all these bad outcomes. So, it's a good temporizing measure, but I think that's really what it is right now.
All right. Well, I think that's about it, sir. I know I personally am honored to be here. I'm excited to be able to share everything with skeletal traction, and especially with such a knowledgeable host. Thank you. That was great. I loved your presentation, and thank you for all the great questions. And feel free to reach out to me if you have any more. I could talk skeletal traction for hours and days on end.
I'm putting my email there too, so feel free to reach out to me as well. I'd love to talk about this, and great job. Thank you so much, John. I really appreciate all your clinical pearls.
Oh man, great job, everybody. Thanks so much.